I work exclusively on the adult side. I am sort of the recipient of young people who have come through the transition process and sort of sadly, oftentimes haven't come through a transition process and they've just been sort of dropped in the clinic without any preparation for that. And you can imagine any young person having to navigate the complexities of our healthcare system now is really challenging. But for a young person that has a lot of medical problems or may have a lot of psycho-emotional trauma from what they've been through or have a lot of dependency on their adult caregivers. I mean, all those things really make this a pretty complicated and really wonderfully challenging population.
Hello and welcome to our WInnovations podcast. I'm your host, Dr. Kyle Richards, and we have a super exciting program planned today. We are now early in season 3 and are thrilled to be back in the Department of Urology studios here at the University of Wisconsin. The purpose of these podcasts is to highlight exciting and innovative work being done here at our institution, but we also bring in some all-star guests from outside the department to provide unique perspectives and also to highlight the collaborative efforts that are required to innovate. Now I'd like to introduce my guests today, Dr. Hadley Wood and Dr. Kristin Ebert. Hadley is a staff urologist in Cleveland Clinic Center for Genitourinary Reconstruction, part of the Glickman Urologic Institute, and professor of urology at Case Lerner College of Medicine. She is the current editor of Urology, the Gold Journal, one of my favorite journals. Hadley completed her medical school training at Johns Hopkins, followed by her urology residency at Cleveland Clinic, where she's been on staff since 2009. She's built really a world-class model transitional urology program, and we are so glad to have her with us today. Welcome, Hadley.
Thanks. It's wonderful to be here. Thanks for inviting me, Kyle.
And Dr. Kristin Ebert, our very own assistant professor here at the University of Wisconsin. She's also co-director of our simulation program. Kristin's a native Wisconsinite and joined our faculty in 2023. She had been working at the Marshfield Clinic in central Wisconsin for 2 years after her training. She did her urology residency at Ohio State, where she was part of a team that won the North Central Section Resident Bowl in 2018. I think probably the highlight of her residency, right, Kristin?
Definitely.
Ultimately, they made it to the semis at the AUA Resident Bowl. Kristin then completed a pediatric urology fellowship at Nationwide Children's Hospital in 2021, and she's been a practicing pediatric urologist since then. She also has a special interest in transitional urology, and this past year opened a dedicated transitional urology program here at UW, which she currently directs, and we're excited to hear more about that. So welcome to the program, Kristin.
Thanks, Kyle. I'm also excited to be here and honored to sit with both of you guys today.
And I know both of you are very passionate about improving and innovating the care of patients with congenital urologic issues. I'm really eager to learn from both of you today. We actually had a great talk this morning from our chief of peds urology, Walid Farhat, on bladder exstrophy. We're really absolutely thrilled to have you both here in the studio for our session today, which we're calling Innovative Approaches to Transitional Urology. I'm going to start with Hadley here. The first question I like to start with is, what is transitional urology? You know, we have a broad audience, some patients, some patient advocates, obviously urologists and trainees, but let's just start with the basics.
Yeah, well, I'm glad you asked it, and also a little sorry, Kyle, because I think there's a lot of different ways that people interpret that term. Technically, transitional urology, or it actually is the process by which a young person, usually starting around the age 12 or so, goes through a process of sort of owning their own medical care, so that by the time they reach maybe their early 20s, they're able to navigate the adult healthcare landscape fairly unassisted. And so that's not just like teaching them the skills to do that. It's also building the infrastructure around them, having the parents and all the healthcare providers help them with that. And it's also building the infrastructure within the systems in children's hospitals and on the adult side. And so I love it that both Kristin and I are here because, I work exclusively on the adult side. I am sort of the recipient of young people who have come through the transition process and sort of sadly, oftentimes haven't come through a transition process and they've just been sort of dropped in the clinic without any preparation for that. And you can imagine any young person having to navigate the complexities of our healthcare system now is really challenging. But for a young person that has a lot of medical problems or may have a lot of psycho-emotional trauma from what they've been through or have a lot of dependency on their adult caregivers. I mean, all those things really make this a pretty complicated and really wonderfully challenging population to work with. And I'd like to sort of have Kristin talk about her side of things, because I think actually most of the work of transition lands squarely in the pediatric urology's office.
Thanks, Hadley. I think, that's a really good summary of it. From my standpoint as a pediatric urologist, it's never too early to be thinking about transition to adult care. And I actually think that that's maybe a weakness within our field itself of pediatric urology, is that sometimes we're just thinking about what's going to get this kid through to the point that they're 18, and we're not really thinking about what happens to that patient when they lose access to the support that they had in childhood, maybe from a caregiver standpoint or from the health system standpoint, et cetera. So transitional urology, yes, we're thinking about that transition from pediatric to adult care, but really these patients need to be thought of as kind of a lifelong care model. And we should be thinking about that, from infancy on. So maybe even at age 6, we're starting to get them engaged with learning how to cath, because that's when maybe they're starting to show interest. So, when I think about my own transitional urology clinic, we found with some surveys that we were doing of our own patients is that we're doing a great job of managing them from a bladder and bowel standpoint, but we're not doing as good of a job talking about things that matter to adult patients. So sexual health, fertility. And then we're also not doing a good job of actually preparing them for that logistical aspect of transition. Who's the right doctor to take care of them? What do they need to become independent? Who's going to be the person who supports them in adulthood? And so the goal of my clinic is to formally introduce some of those topics and ask the patient and their caregiver, if they're involved, what their goals are and how we can support getting them into the adult world, in the best way possible.
Yeah, I like that. It's never too early to start the transition. It's almost like discharge planning to some extent in the hospital, right? You start that at the time of admission.
It's a years long discharge planning, right?
Yeah, exactly.
Well, and if you actually think about the definition of transitional care, it's a transition from one type of healthcare to another. So, the same basic principles all apply.
I want to just make one more comment. One key aspect when you talk to people that are really good at this is, especially in pediatric life, is really, meeting the young person where they are developmentally. And obviously, that's such a focus of all of our pediatric care partners. But, once they come into adult life, they're not like fully formed adults. And especially if they have any intellectual disabilities or they've had learning disabilities, they oftentimes are still in young adulthood or even late adolescence intellectually and developmentally. And so I think that what Kristin just mentioned, like if they're 6 years old and they're ready to start cathering, that's great. But there may be 18-year-olds that are still like really struggling to sort of do basic self-care needs. And sometimes they can't quite get there when they ultimately do have to transition, because some systems and insurance companies and that sort of thing require transition by age 26. And so there's a lot of shades of gray here, and being sensitive to the patient's needs and meeting them where they are is really critical aspect of being successful in this space.
Now, I'm curious to sort of hear from both of you how you got interested in this space and in this field. Maybe start with Kristin for this one.
Yeah, I think maybe I'll just start from the beginning. So, I decided I was going to do a pediatric urology fellowship during my 3rd year of residency. And then by the time I finished residency, part of me wondered if I had made a mistake, because I really loved adult urology too. And so I think I'm a pediatric urologist who's always loved adult urology. And then in fellowship, we had kind of a unique system in that we didn't transition our patients. So we still had 60-year-olds coming to our spina bifida clinic. And so I really got kind of a cool opportunity during fellowship that I wasn't just taking care of kids, I was also taking care of adults and kind of doing that, transitional congenitalism work within fellowship. And I just really enjoyed that population. And it got me thinking a lot about kind of like what I was alluding to before. Are we doing the right thing as pediatric urologists for these patients when they get to adulthood? Because I'd see them come back, maybe a spina bifida patient who had gained a significant amount of weight and now their cath channel had stenosed, or a patient that we closed off their bladder neck and they lost the social support that they needed and they came in renal failure. And so one of my passions and one of the things that I dream of is really trying to figure out what's the right surgery that we should be doing for these patients the first time around. So that's, kind of what got me interested in this population. So yeah, I'm really excited to kind of be living the dream now in Wisconsin and doing that work.
And what about you, Hadley? What was it that drew you to this population?
I would say it's like the mirror image of Kristin's. I had a very influential mentor in medical school, and John Gearhart, who many people listening to this will know is an icon in pediatric reconstruction, and went into residency thinking I would do pediatrics, and then had a lot of exposure to reconstructive urology, which at the time was a pretty narrow field, and sort of envisioned like there's a space here for people to be doing really great reconstructive work within the context of sort of a pediatric framework, but on adults. And so I just sort of landed there, and there were a lot of patients. And I was able to sort of build that a little bit with the support I had around me. And then the other thing that happened shortly after I came into practice is we were without a pediatric urologist. So I was asked to help keep the pediatric ship going a little bit at Cleveland Clinic. And so I was able to work with some of the local pediatric urologists in Akron and elsewhere and really be mentored by them. I got to know them. They got to see how I took care of patients, so that when I was able to step away from pediatrics, they sort of knew, oh, here's this person that's really willing and wanting to take our patients that we're trying to graduate to someone who cares about their needs and knows about them. So it was a little terrifying to sort of start practice in that space, but it turned out that it was actually quite a great thing for my career. I learned a lot.
Yeah, that's fantastic. Great to hear about your mentor, Dr. Gearhart. We all have mentors. Kristin, I oftentimes will ask our guests about their mentors or pay some homage. So we've heard about Dr. Gearhart. Did you have a mentor or two along the way that really got your sort of wheels spinning in this area?
Yeah, I mean, I was lucky enough to do residency and fellowship at the same place. So I really kind of got to develop that longer relationship with mentors. But, Rama Jayanthi is the chief of my division, and he's a great mentor, a great surgeon. And I think Molly Fuchs and Daniel DeGiusta as well also did a lot of complex reconstruction and also enjoyed taking care of that adult population, and were inspiring to me in that way.
That's great. Switching gears a little bit, I've heard you guys talk a bit about some of the challenges of taking care of this patient population. And certainly there's surgical challenges, there's psychosocial and systems challenges. Maybe Hadley, could you just elaborate a little bit more, maybe on some of the system challenges that impact the care of these patients?
Yeah, I mean, every geographic location is different. For example, at Wisconsin, you have a children's hospital, which I believe is a separate sort of financial entity, a completely separate entity than the University of Wisconsin adult side. Is that correct?
Correct.
Yes.
I mean,
yes.
What do you think, Kristin?
I know they're the same department, but there's all sorts of different nuances to this, whether you have integrated pediatric and adult or you have separate freestanding hospitals, which is like an automatic setup. Even if they're like physically different buildings, it's like more complicated, right? To get a patient, to learn a new facility. And as most people listening to this know, like the pediatric hospitals are just amazing. They've got like ponies and clowns and multi-specialty clinics and all these resources for families. And then they get dropped into the middle of like a giant, facility where radiology is, a mile and a half away from the physiatry. And then, urology is in completely another building. Just the physical plants, I think, are quite difficult for patients to navigate. And then there's all the insurance complications, navigating, putting together multiple specialists, and this is especially true for patients that have complex disease, like patients with spina bifida or with other types of like muscular dystrophies and that sort of thing. So they may have GI specialists, they might have urologists, they may have physiatrists, and they have all these needs. And it's really hard to sort of get everyone on the same page, much harder at an adult facility because of the silos that are built in the larger facilities. And so I think that's probably, in my opinion, the biggest systemic challenge for the patients to navigate. I don't know. Do you have an opinion about that, Kristin?
Yeah, I think you hit the nail on the head with, the fact that most of these patients need more than one specialist, and especially for like our spina bifida patients who are used to a multidisciplinary clinic when they're younger. All of a sudden now they have to find a new orthopedic surgeon and a new neurosurgeon and, a new urologist. And I've found that the most challenging patients that I've seen in my clinic so far are the ones who aged out of pediatric care and then kind of decided, I don't really need to be seen. I'm doing okay. I order my own catheters online or whatever it is. And then they come into the ER with a crisis. And then we're trying to kind of build everything again from the ground up. And that's tough. I think the other aspect that's been hard for me is that there's not a set standard in place for transitional care. And so I can be doing a great job from urology, but patients may not be getting the continuity of care that they need from the other surgical subspecialties or nephrology or what have you. And so then a lot of times those patients are actually coming to me almost like their PCP because they're like, well, I know you do a great job with talking about this. So, can you help me figure out, who should my new PCP be and who should my new GI doctor be and those sorts of things. And so it's hard because you try and do a great job and it can be a lot of work.
Yeah, definitely. And even like on the adult side, the specialists aren't like a one-to-one translation. Pediatric orthopod is going to do everything. They're going to deal with lower extremity contractures, shoulder things, back spine stuff. And then you get to the adult life and you're like, oh, you've got spinal stenosis, you got to see a spine surgeon. You got a shoulder problem from being in a self-propelled wheelchair, you got to see a shoulder person. You got a wrist problem, you got to see a hand person. And so, these patients can have 4 or 5 different orthopods for all their different problems. And that's true. I'm not just trying to gang up on orthopods. I think it's true in like lots of subspecialties and just the adult side is just so much more fragmented than the pediatric side.
Yeah, and that's actually a great point. I can think of some patients that have sort of come back to the pediatric world because they needed better help with transitional care, but who have been seeing this urologist for stones and this other one because they have a pessary and, this other person's managing their neurogenic bladder needs. And it can be tough for me as a peds urologist trying to even find the right fit who can deal with all of the problems that they have from a urology standpoint.
Yeah, I'm hearing that there's a lot of coordination of care that needs to happen, and there's a lot of communication, certainly, that needs to occur, which I think is a good segue to sort of the next question that I wanted to pose to, and maybe I'll start with you, Kristin, since you've just kind of gone through this process the most recently in establishing the Transitional Urology program here at University of Wisconsin. How did you do it, and what are some sort of pitfalls and things you learned along the way?
Well, I'll put out the disclaimer to start that this is still a work in progress. So it's certainly not built all the way. And I think there's lots of room for growth, but it's exciting. I think the number one thing that you really need is institutional buy-in and support for this. So I have to thank Steve Nakata for supporting us in building this program in the first place, because if you don't have that buy-in, these are hour-long patient visits. These are not revenue-generating patients, So I really think that you need to have the support from the institution that they think this is a worthwhile venture. And kind of with that being said, as a pediatric urologist, I also think you really need buy-in from the adult side. You need at least somebody who's interested in accepting these patients or the program will fail. So I'm super lucky to have Dr. Javi Santiago here, who trained with Dr. Wood. So he's been great so far. So we love working with him. He joined us this past fall and has come to the transition clinic a few times to kind of get oriented to it. And the plan is to have him start coming every single month starting in June. So that's timing kind of works out well because that's when a lot of my patients are going to be sort of ready for that transition. I think having that pediatric and adult collaboration in the clinic has been a key to success for me. Future goals, we have a nurse practitioner that comes to our clinic, but I'd love to have a care navigator, a social worker, those are the dreams, for the future, but we're still building it and learning.
Well, I'm excited to see where it goes, and kudos for getting to this point. What about you, Hadley? How are things at Cleveland Clinic? How does that sort of compare to how you set things up?
Well, I'll say, I've been at this now for a long time, 15 years. And I don't think we've still cracked the nut. I do have an adult spina bifida care clinic that's multi-specialty, and that's very helpful. And then I have this cadre of people on the adult side who are really good at taking care of adults with various different congenital diseases. And that includes, patients who Vactoral type patients who may have congenital cardiac disease and that sort of thing. Like there's just so many different needs that these patients have in all these subspecialty areas. So I feel lucky that I have that. And most of the people working in this space are really, really devoted to this patient population. But I will say that on the adult side, we just don't have things like social workers. Like this, if I need a social worker to help a patient of mine, I usually have to lean on the med peds doc that works in our adult spina bifida clinic to see if he can get this person some help out of his clinic, because we don't have social workers in the adult urology field. So, and I think that's just sort of part and parcel to adult care, but it's also one of the things that makes it challenging for these patients to come over onto the adult side, because then they're like, where are the care navigators? And you're like, I'm it. I'm doing all of it. I'm scheduling you. I'm telling you where to show up, and I'm going to be your doctor. So it is a little bit more independent.
And do you have a collaboration with the peds urologist as well, Hadley, or how does?
Oh, for sure. Yes. And I'll just tell you how we made that work best is we are an integrated hospital. And so we have our pediatric team, and then we actually have 2 people doing congenital urology on the adult side. But we have this just rock star of a nurse practitioner who's actually double boarded in adult and pediatrics. Her name's Kim Slocum. And she actually staffs both spina bifida clinics, and she's also really well trained in transition. So when a patient is identified as needing to sort of work the process, the transition process, she actually sort of does a bunch of sessions with them that are just specifically focused on transition preparation. And then sometimes we'll have a combined meeting with her and me, or sometimes she'll just say, okay, now it's time for you to go see Dr. Wood, or we'll do a virtual or something like that. She sort of decides based on what the patient's needs are and their location and that sort of thing, how we're going to do it in a way that meets, the patients where they are. So building a big infrastructure around it didn't really work for us. And so it was really just having someone with the right expertise, and our team is really close. So it's sort of just like a pretty smooth handoff. And she's a pretty familiar face on both sides, peds and adult.
Yeah, I just want to echo Hadley's comments that I think a nurse practitioner is really key to the success of this program. So we're lucky to have Callie Mesjin here, and she's been instrumental, with helping also get the clinic off the ground. Just that ability to sort of, cross over from the peds to the adult side, work with Hobby, work with myself. It's really important to have.
I'm going to switch gears a little bit and maybe ask Hadley this one, since she's a little bit more senior than Kristin. Is there anything organized urology can do to help with transitional urology programs? I know Kristin mentioned cost and reimbursement, and these are visits that are lengthier and might not be cost effective for the institution. So is there anything that organized urology can do to help support these patients?
Yeah, I think the most important thing is advocacy. And I would say that the one patient advocacy group that's most effective in the advocacy space would be the Spina Bifida Association. They do a big advocacy summit called Teal on the Hill every year, where they're going to Congress people's offices and they're talking about what the needs are of this population. Understandably, the AUA is more focused on things like prostate cancer and the bigger ticket things that more urologists are facing. But this is a very necessary population. And I will say that if we don't advocate for the needs of these individuals as they go into adult life, we've really failed our jobs as urologists and as a urological community to give them the promise of having a good life and give them a urinary diversion and help them live into adulthood, and then just be like, okay, our job is done. There's nothing on the other side for you. And there's a lot of ways to do that. One is to compensate for the extra effort that it takes to help these patients be successful in a way that mirrors the amount of work. I think the second thing is just a lot of things related to support, paramedical stuff. Things like DME that they need at home, or even appliances. Like a lot of Medicaids only cover one type of appliance or one type of catheter. These patients often have very unusual physical needs and anatomic needs. They may have terrible scoliosis. They have to be in specific types of appliances, and they just can't get them, and they're really expensive. And so those are the kind of things that I feel like me and my nursing team spend a lot of time doing, and should be easier to make that argument. It's not a huge population, but getting them the right care that they need will keep them out of the hospital, because when they land in the hospital, it costs mostly a state-funded and federal-funded taxpayer money, a lot of money to get them better again because of how complex they are.
Yeah, I think that's a great point about these hospitalizations. Like Kristin pointed out earlier, it tends to be crisis scenarios and expensive hospitalizations, admissions for pyelonephritis and infectious diseases. And also with these cuts that are being proposed to Medicaid, these could be really devastating for many of these patients. So the advocacy is so important. We just had the AUA Advocacy Summit, and I think specialty societies also can play a role here. Kristin, what do you think about organized urology? Anything else to add to Hadley's wonderful points?
Yeah, a few things. So working on tools that we can develop for these patients to help navigate the transition. That's actually a research interest of mine, to try and develop tools that we can use to give to patients that they can take from one doctor to another, or ideally, eventually, I'd love to be able to build something that can be integrated into our EMR. So, health systems should be kind of, in my opinion, prioritizing research into this space, because this is something that can be translated not just from urology, but into other chronic pediatric diseases that are going to need transitional care. I have kind of an unpopular opinion, maybe, about what we can be doing from an organized urology standpoint, which is that I think that pediatrics needs to be a bigger focus in residency training now. Not necessarily because residents are going to go out and do pediatrics, but if we want people in the community to be able to care for these patients and have enough people who can see them, we need to do a better job of getting our residents exposed to pediatrics instead of kind of really thinking about this being such a siloed world. I'm biased because I love, both, pediatrics and adult urology. And so, I really enjoy that idea of care across the lifespan, but that's the way things historically were done. And I do think that there's some benefit to that. So I think also more training, maybe transitional urology fellowships, or thinking about maybe peds urology fellowships that are only a year long, with kind of the goal of maybe not doing an extra fee closure in practice, but just having more exposure so you can do bread and butter peds cases and take care of congenital patients that are adults out in the community. So those are some of my ideas.
And that's a good segue, I think, to sort of what the future of transitional urology looks like. And you hit on some of those points, having a fellowship, a one-year fellowship, getting our residents more exposure, I think, is also a fantastic strategy. I certainly loved my pediatric urology experience at Wake Forest with Gordon McClory. The late Gordon McClory was one of my mentors, and really loved working with him, doing some reconstructive peds urology. Hadley, where do you see the future of the field heading?
Well, is this a pie in the sky, like wishful thinking? Because I would tell you that I would love to see funding organizations fund projects that are more lifespan approach. Right now, the way that I know there's a larger concern about funding down the road anyhow for research, but I'd love to see, we see sort of pediatric focused funding mechanisms and adult focused mechanisms. I'd love to see true lifespan approaches. And I think that would go a long way to bringing actually pediatric and adult providers together to discuss these things in the same space. Even the way that we have, AUA designed, it's like impossible to see what's happening in transitional urology on the pediatric side and the adult side, because those sessions are often running concurrent. And so I really think that we have to keep working to try to get everybody in the same room talking about this and learning from the models we're testing, and then moving forward together. So that's been sort of actually my lifelong commitment in urology, and will continue to be till the day I set my scalpel down.
Hadley, I actually have a question. Is there a working group through the AUA on transitional urology?
There was. We had one going for about 6 years. And it's sort of like the formal working group sort of petered out a little bit with the changeover of not even the current, but the secretary prior to this one. So there still are workshops and that sort of things, but there just didn't seem to be a ton of appetite from a lot of that happened like concurrent with when the AUA sort of shortened its length. And so they were like, we just physically can't do this. We can't like make space for this extra piece that's been carved out for both adult and pediatrics. So
it's a shame. Maybe we should revive it. because I'd certainly be interested.
I'm happy to do that. Yeah.
Anything else, Kristin, from your standpoint, to add to the future of transitional urology, pie in the sky type things?
Yeah, I mean, I actually think it's really funny that Hadley said that, because when I was reflecting on this question, I was like, is this where I actually see it going or my dreams for it? Because it's such a challenging field that it can be hard to be optimistic about it in the time. So, I mean, my pie in the sky dream is like what I said, is that we see less siloing, and what Hadley said, more of us working together from the peds and the adult standpoint. So with maybe some of those strategies that I talked about, but in the meantime, hopefully maybe some transitional urology fellowships or just more people interested in congenitalism can kind of help bridge the gap. I think institutions should prioritize hiring people with an interest in this. It's becoming more and more of a pressing issue, and it's only going to continue to be that way.
Well, you both are just wonderful surgeons and role models, and I think the more we talk about this, the more word gets out, and hopefully this podcast will help at least raise awareness to some of these issues and get more people interested and engaged in the field. So thank you, Hadley, for being with us tonight.
Oh my gosh, thank you so much for having me. I'm actually going to be heading your direction in less than 48 hours and look forward to seeing you both.
That's right. Hadley will be our esteemed visiting professor at the Wisconsin Urologic Society meeting coming up here in Madison. Yeah. And we look forward to seeing you there. And Kristin, thank you so much.
Thank you guys so much for having me. I really, like I said, I'm honored to be here with both of you. So thank you.
I have to just close this. I think my husband would kill me. He's a Badger. So if I don't close out by saying go Badgers, I'm going to get in a lot of trouble with him. So go Badgers.
Agreed. Go Badgers.
Awesome. Well, we love your husband as well. So that's great. And thank you all so much. This has been just a great discussion with Dr. Hadley Wood, Dr. Ebert here talking about innovative approaches to transitional urology. Thank you all for tuning in tonight. I want to thank our producer and editor, Sandra Miller, as well as our chair of the Department of Urology, Dr. Stephen Nakata. And signing off, so long, this is Kyle Richards, host of WInnovations.
WInnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.